Hello, everyone. Today we are joined by a guest from Switzerland, Chris Brönimann. Welcome, Chris. It is a pleasure to have you here in Istanbul.
Thank you for your invitation, Professor Zeki. I am very happy to be your guest here in Istanbul.
So, who is Chris Brönimann and why have we invited him today? Chris is a detransitioner. What does that mean? A detransitioner is someone who has undergone a gender transition and later decided to reverse that transition or return to living as their birth sex. Who undergoes gender transition? Transsexual individuals seek to transition from one sex to the other through hormone therapy and surgery. In other words, a biological male wishes to become a woman, while a biological female wishes to become a man. Chris was born male and raised as a boy. At the age of 29, he underwent sex reassignment surgery and then lived as a transgender woman for approximately 26 to 27 years. He became one of Switzerland's best-known transgender women, arguably the most well-known. He was an iconic transgender figure and spent many years as an activist. Eventually, however, he publicly acknowledged that he regretted his transition. And since 2024, he has been undergoing the process of detransition. Before we begin our conversation, I would like to briefly explain the developmental experiences that led him down this path so that our audience can better understand why we invited him. Chris is of German origin. He was born in Germany in 1969. During the first years of his life, he experienced extremely severe physical and psychological trauma. These early experiences played an important role in the development of his transgender identity and contributed to the path he eventually followed. What happened? During his first years of life, because of his mother's intellectual disability, he suffered severe physical and emotional neglect. In his own words, "When I was 5 years old, my mother would leave me alone for days, hungry, neglected, and even lying in my own feces." His father was suffering from terminal cancer and was unable to care for him. When Chris was about 3 years old, his father notified the authorities, and Chris was placed in a children's care facility. He remained there for 6 months because he was severely underweight, malnourished, developmentally delayed, and suffering from rickets. After 6 months of care, his condition improved somewhat. Nevertheless, the neglect continued. Eventually, at around the age of 5 or 6, he was adopted by a Swiss family and has lived in Switzerland ever since. About a year after the adoption, his adoptive parents had biological children of their own. Chris recalls, "Once again, I was marginalized and neglected. That child became the prince of the family, while I was subjected to violence." During this time, he also noticed that 4 girls living in the neighborhood, who were about his age. They were always beautifully dressed, well cared for, and treated affectionately. As a child, he drew the following conclusion: if you're a boy, you get beaten. If you're a girl, you're loved. This illustrates the very mechanism that we often discuss. It reflects a developmental process that can contribute to gender confusion in susceptible individuals. In Chris's case, masculinity became associated with danger, while femininity and being female came to be perceived as safer and more desirable. As a result, he gradually developed gender confusion and later gender dysphoria. During adolescence, he experienced same-sex attraction, while the neglect continued. He also says, "At school, I was always marginalized. I was bullied. I was constantly beaten." The combination of his experiences during early childhood, his school years, and adolescence ultimately led him into the transgender world, where he attempted to change his sex through hormone treatment and surgery. As you know, sex cannot actually be changed. It can only be surgically altered or removed. I would like to make that point here as well. We will, of course, hear Chris describe his own journey in his own words. At the age of 29, in 1998, he completed all of his gender transition surgeries. Originally named Christian, he became Nadia and lived as Nadia for approximately 26 to 27 years, nearly 3 decades. Swiss national television closely documented his story. A television crew followed him for 6 years, filming his transition, including his surgeries in the first years that followed, and produced a documentary about his life. Following this 6-year documentary project, he continued to live in Switzerland as an iconic transgender figure and transgender activist until around 2020 or 2021. After that period, however, he was already struggling with profound physical difficulties, psychological distress, and growing regret. Like many other transgender individuals, he felt unable to acknowledge these feelings publicly. Beginning in 2024, however, he openly declared his regret and began his detransition. Today, he identifies as a detransitioner. He is now striving to return to living as a man. He was born Christian, later became Nadia, and today he continues his life as Chris. In fact, just last week, he was finally able to have the name Chris officially registered on his identity documents. He expedited the legal process so that he would not encounter any problems while flying to Istanbul, and he has now received his new identification documents. So today, he joins us as Chris Brönimann. With that introduction, let us begin our conversation. Dear Chris, you began your transition process when you were 25 years old. More precisely, that was when you started your transition, while you underwent surgery at the age of 29. You wanted to change your sex through surgery. You wanted to transition from living as a man to living as a woman. How many times did you meet with psychiatrists before beginning this process? How long did those consultations last? Did you feel that the assessment was sufficient? Could you briefly tell us about the psychiatric evaluations and reports that were prepared before your transition was approved and initiated?
At that time, in the 1990s, when I began my transition, the system in Switzerland was actually quite well organized. Normally, before a person could be referred to an endocrinologist, 2 independent psychiatric evaluations were required, and both reports had to confirm a diagnosis of primary trans identity. Looking back today, however, I realized that my own behavior at the time was a complete disaster. I managed to bypass the entire system. To be honest, I had no interest in undergoing psychotherapy. I was young, and I had an overwhelming desire to transition. I kept asking myself, why should I have to go through psychotherapy? So I turned to the black market and bought the first psychiatric report. At that time, I paid about 700 Swiss francs. All I had to do was hand over the money, and just like that, I had my first report. For the second report, I went to the psychiatric outpatient clinic at the University Hospital in Zurich. I was supposed to have an assessment interview with a professor, but I knew exactly how I should dress, what I should say, and how I should behave. I knew precisely how to present myself in order to perform the role of a woman as convincingly as possible. And it worked. I spoke with him for only about 20 minutes. After that, I received the approval. Christian Brönimann, also known as Nadia Brönimann, has a primary transgender identity. We are referring you to the Department of Endocrinology. That was how I got around the entire system. It was remarkably easy, far easier than it should have been. Looking back today, I believe that what I did was completely wrong, unfortunately.
Yes, unfortunately, this is often how the process unfolds. What Chris has just described is consistent both with the scientific literature and with my own clinical observations. In many cases, the transition process is initiated after insufficient psychological evaluation, even though it is a process that involves irreversible loss of organs, tissues, and bodily functions with potentially profound and permanent consequences. I have seen this firsthand in patients under my own care, and the medical literature clearly documents the same concern. For example, in a study published a few years ago by Lisa Littman, interviews with detransitioners revealed that 55% of those who had transitioned and later regretted their decision felt that they had not received an adequate psychological assessment before beginning their transition. Moreover, a substantial proportion of these detransitioners never even informed the physicians who had overseen their transition that they had detransitioned. They simply did not want to see those doctors again. Chris's experience is consistent with these findings. Unfortunately, this remains the reality. Let me move on to my next question. As with every surgical procedure, patients must be fully informed about the potential risks and complications before surgery. This is one of the fundamental principles of medical ethics and is known as informed consent. We are obligated to provide this information before every operation we perform. In major procedures such as gender transition surgery, which involve the irreversible loss of organs, tissues, and bodily functions, our ethical responsibility to ensure truly informed consent is even greater. Before your surgery, did your surgeons provide you with sufficient information about the possible complications? Did they obtain your informed consent through a thorough discussion? Do you feel that you were adequately informed about the risks and potential complications?
In my case, there was hardly any real informed consent process at all. I started hormone therapy, and to be honest, that was extremely easy. You simply took the tablets and, well, I did not even attend regular follow-up appointments. Everything moved forward very quickly. When the surgical procedures were finally discussed, I remember that there was an information session, but it was really nothing more than a formality. The surgeon explained everything very casually, almost as if he were mentioning it in passing. First, he spent quite a while telling me how wonderful the outcome would be. He said, "We are going to create a very good neovagina for you. Afterwards, it will be just like that of a biological woman. You will be able to experience orgasms. You will have sexual arousal. After the operation, you will be a perfect woman. You will enjoy a satisfying sexual life." That was what he emphasized. Then he said, "All right, Nadia Brönimann, we also have to discuss the risks and possible complications. They are listed on this sheet of paper. Yes, this complication may occur, that complication may occur, and things can go wrong, as with any operation. But everything will be fine in your case. Here is the form. Please sign it." The whole discussion lasted about 5 minutes. I don't really know exactly. But to be honest, at that point in my life, I was perfectly satisfied with that. I never questioned anything myself. I simply believed that nothing could possibly go wrong with my own operation. I was convinced that everything would turn out perfectly. Complications? Yes, they're written on the paper. Fine, I'll sign it. And then it was simply, "Please proceed to the operating room." I was very naive.
Yes, unfortunately, this too represents a serious ethical violation. The potential complications were not properly explained. Instead, the informed consent process was reduced to merely signing a few routine forms. Unfortunately, this constitutes a significant breach of medical ethics. My next question is this. You underwent surgery at the age of 29. When you woke up after the operation, when you regained consciousness from anesthesia, what was the very first feeling you experienced? What went through your mind? What did you encounter? What were your first thoughts after the operation?
On the evening before my first surgery, I created what felt like a farewell ritual. I made it into a dramatic event, complete with music. I truly believed, I am going into this operation, and I am going to die. Christian will die. When I wake up, I will be Nadia. I will be a completely new person. It was a romanticized fantasy, an illusion. It had nothing to do with reality. The reality was this. I spent 6 hours on the operating table. When I woke up from anesthesia, my very first thought was, I'm still me. At that moment, my mind, or perhaps my soul, gave me my first reality check. You're not a different person. Yes, you've had surgery, but you're still you. I didn't want to accept that thought. I recognized it, so I chose to push it aside instead of exploring what it meant. Looking back, however, that thought was incredibly powerful, wasn't it? Because the realization, I'm still me, actually says so much.
Yes, this confirms exactly what I have been saying all along. Sex cannot actually be changed. What surgery can do is alter a person's anatomy and remove or damage the genital organs. That is why I say that sex is not changed, but rather abolished. Chris has now experienced this firsthand through a very painful personal journey. As he has just explained, when he woke up after surgery, he realized that his sex had not changed at all. The operation had only altered his anatomy. He later experienced the complications of that surgery as well, and we will discuss those in more detail. Now, let me move on to my fifth question. Including the operations performed to treat post-operative complications, you underwent a total of 16 surgical procedures. Were the complications that developed after these operations ever successfully resolved? Some of what you experienced may be highly personal, and of course, you do not have to share everything here. However, could you tell us about the aspects that you have already discussed publicly? What is your condition today? Functionally, what is your current situation? What biological problems are you living with? Could you briefly tell us about them?
As I mentioned earlier, my first operation lasted about 6 hours. As far as I know, everything initially seemed to go reasonably well during the procedure itself, although I lost a considerable amount of blood. However, complications developed very quickly after the surgery. I developed infections, excessive granulation tissue formed, and within a short time, a second corrective operation had to be scheduled. At the same time, I had to receive morphine for about 11 days. Looking back now, I realize that at the time, I actually appreciated it. Today, I see it very differently. The morphine kept me in a kind of sedated, almost intoxicated state, so I hardly felt any pain. During those 11 days, I kept thinking, this transition surgery, this genital operation, is actually quite easy. I'm doing well. Everything is wonderful. But after 11 days, the morphine had to be discontinued. That was when the pain really began. My God, that was when everything became difficult. At about the same time, I reached the stage when I was supposed to begin vaginal dilation. The newly created wound, the neovagina, had to be kept open using a dilator every day. But from the very beginning, that simply did not work for me. It caused me tremendous pain. I could hardly perform the dilations at all. Naturally, I asked my doctors, why am I in so much pain? Why isn't this working? The only answer I received was, it will get better. You need more practice. You need to relax. Give yourself time and keep dilating. But it did not get better. On the contrary, the infections became even worse, and I had to undergo a second operation. The doctors told me, don't worry, we'll operate a second time. After that, everything will be perfect. Once again, I allowed myself to hope. All right, I said, let's go ahead with the second operation. The second operation was performed, but once again complications developed afterward. It became like a row of falling dominoes. The first operation led to the second, then the third, the fourth, the fifth. Every time there was the same hope. The next operation will fix everything. And every time that hope ended in disappointment because nothing was actually resolved. Instead, each operation led to even more complications. Again and again, I developed infections, scar tissue, fibrosis, excessive granulation tissue, and recurrent narrowing of the neovagina. I could not perform adequate dilation. The neovagina continued to scar over and contract. Nothing ever worked the way it was supposed to. Eventually, I reached my 14th operation. By then, I could tell that my surgeon was becoming impatient. Once again, I went to him and said, "Doctor, it's still not working." I could feel that he had lost patience with me. He replied, "All right, come in for a short general anesthetic. We'll perform a vaginoscopy and have a look. By now, everything should be fine." But I knew my own body. I knew something was still wrong, and I felt that he no longer believed me. So I underwent what was supposed to be a brief anesthetic for a simple vaginoscopy. Our agreement was straightforward. I would be asleep for about 5 minutes. They would examine the neovagina, wake me up, and I would go home. But that is not what happened. Several hours later, I woke up in the intensive care unit. I had a colostomy, a stoma. It was an enormous shock. Mrs. Brönimann, we're very sorry. During the vaginoscopy, we found new scar tissue in your neovagina. Since you were already under anesthesia, we decided to release the scar tissue. Unfortunately, too much pressure was applied, causing a tear in the rectum, the final part of your large intestine. We therefore had to perform emergency surgery and create a temporary protective colostomy. Otherwise, your life could have been in danger. For me, that was an overwhelming shock. It truly marked the lowest point of my entire journey. Professor Zeki, what affected me most was this. I had never consented to that operation. Our agreement had been for a 5-minute vaginoscopy. I was supposed to wake up afterward and go home. I had never given permission for another surgical procedure. They should have woken me up first and explained the situation to me. They should have said, "Mrs. Brönimann, we have found another problem with your neovagina. We believe another operation is necessary." Instead, they simply went ahead. Without my consent, they operated, caused a tear extending from the neovagina into my rectum, and I ultimately had to leave the hospital with a colostomy. That was truly the lowest point of my life. It also marked the end of my surgical marathon. Fortunately, after my recovery, the colostomy was eventually reversed. Afterward, a follow-up consultation had been scheduled to discuss what should happen next and how my treatment would proceed. On the day of my appointment, I arrived at the hospital. The receptionist simply told me, "Your file has been closed." I was completely surprised. "What do you mean? I have an appointment with my doctor." "No," she replied, "your file has been closed." And that was the end of everything. That was the end of my surgical journey in Switzerland. 16 operations. Each one carried the promise that I would finally have a satisfying sex life, a functional female genital organ, or at least a functional surgically created genital organ. But what was the final result? What I was left with was little more than an imitation, something that functioned only well enough to allow me to urinate. Everything else was gone. There was no sexual arousal. There was no sensation. Penetrative intercourse was impossible. I could not experience orgasm. It felt like dead tissue. That was the outcome. The difference between the dream I had been promised and the reality I ended up living with, that is something you simply have to live with. Yes, Professor Zeki, ever since then, and it has now been almost 30 years, I have been living with this so-called neovagina, or whatever you want to call it. I am now 57 years old, and in addition to everything else, I also suffer from urinary incontinence. There is nothing amusing about that. I had imagined a completely different life. I trusted surgery. I trusted transgender medicine. But the promises that had been made to me were never fulfilled. Living for 30 years with something that is essentially an imitation, living with an organ that does not function, that is an enormous burden, a lifelong struggle. And I continue to live with it to this very day. But at what cost?
Yes, unfortunately, Chris has just summarized many of the problems we observe in individuals who undergo gender transition surgery. I had told him that he did not need to go into great detail, but as you have seen, he has openly shared many aspects of his experience. What have I been saying all along? Individuals who undergo these procedures do not actually change their sex. Rather, they undergo urogenital mutilation. Let me briefly summarize the problems that affect nearly all individuals who undergo these surgeries. First, every patient irreversibly loses the ability to reproduce. This occurs in 100% of cases. It is not considered a complication because it is an expected consequence of the surgery. In addition, numerous post-operative complications may occur. As Chris has just explained, many patients also lose their sexual function. Chris himself says, "I completely lost my ability to experience orgasm. I no longer have any sexual sensation. The only function I have left is the ability to urinate. And even that has become impaired because in recent years I've developed urinary incontinence." He also suffers from recurrent episodes of chronic cystitis, something we see in many transgender women after surgery. I would like to emphasize one point once again. There is, in my opinion, a major misconception surrounding these procedures. People are told that surgeons create a new penis or a new vagina.
In reality, what is created is neither a penis nor a vagina. A neovagina is not a biological vagina, but a surgically created cavity in the perineal region. Because the body recognizes this cavity as a wound, it naturally attempts to heal and close it. In approximately 2/3 of cases, significant narrowing or closure occurs. Even when complete closure does not occur, the neovagina often becomes stenotic, making penetration difficult or impossible. Even when penetration remains possible, there is no normal erogenous sensation. In my opinion, presenting this as the creation of a normal female genital organ is misleading. Normal female sexual function cannot be recreated because a biological clitoris cannot be recreated. Beyond these issues, approximately 1/5 of patients experience major complications such as bowel injury. Unfortunately, Chris experienced exactly that. As he described, while surgeons were attempting to reopen his stenosed neovagina, his rectum was perforated, making a colostomy necessary. The large intestine had to be diverted to an opening in the abdominal wall, requiring him to live with a colostomy bag for many months before another reconstructive operation could be performed. Complications such as bowel injury occur in approximately 1/5 of patients. However, the complications Chris mentioned earlier, particularly narrowing and closure of the neovagina, occur in nearly 2/3 of cases. Loss of sexual function occurs in the vast majority of patients, while reproductive function is permanently lost in every case. Unfortunately, these risks are often not adequately explained. Many surgeons do not fully discuss them. Activists frequently minimize or conceal them. As a result, many patients are misled. In my opinion, this represents a profound failure of care. And sadly, members of our own profession are sometimes part of that failure. Chris, what you have shared today points to another important issue. These complications are often concealed. Many physicians and surgeons do not adequately discuss them with their patients. Many transgender individuals who experience these problems remain silent. They are often reluctant to talk about their urogenital complications or disclose them publicly. Researchers from Switzerland, including Kuhn and colleagues, have reported the same observation. Transgender individuals who have undergone surgery are often very reluctant to report urogenital complaints. Consequently, these complications are likely to be underreported in the scientific literature. In other words, although the complication rates reported in published studies are already high, the true rates may be even higher in clinical practice. Many continue to present themselves as happy trans people. You have also said that you played that role yourself for many years. We will come back to that shortly. So let me ask you this. Isn't this the real form of transphobia? Misleading transgender individuals, causing them harm, withholding important information from them, promising them an idealized future, almost a paradise, and then confronting them with a completely different reality. When we consider all of this, isn't this the true systematic form of transphobia?
Yes, I believe it is. That is exactly how I would describe it. In many ways, it is a paradox. People are promised something. They are sold an illusion. These operations are presented under the banner of happiness, compassion, and helping people. Patients are told, "We will help you become happy. After the surgery, you will finally feel good. You will be free, and everything will fall into place." The message is essentially, modern medicine can make anything possible. But reality turns out to be very different. What I genuinely do not understand is that medicine deceives vulnerable people on two different levels. First, they are led in the wrong direction through promises that conceal the real complications. These operations are offered while the risks are minimized or hidden. People believe those promises, just as I did. We trust medicine. Patients trust their doctors. Then the outcome is nothing like what was promised. Irreversible harm occurs. And after that, medicine abandons the patient. The patient is left alone with a permanently damaged body and must somehow learn to live with it for the rest of his or her life. First, people are promised successful surgery, perfect sexuality, the ability to experience orgasm, and lasting happiness. Then, precisely when they need help the most, medicine is nowhere to be found. It is almost as if they are told, "Well, good luck. Now you have to figure out for yourself how to live with this." For me, that is not ethical medicine. For me, it is irresponsibility. And in my opinion, that is the real transphobia.
Chris, as you know, transsexual individuals do not have a physical disorder, a hormonal disorder, or a genetic anomaly. If such a condition exists, we classify it as an intersex condition. That is entirely different from transsexuality or homosexuality. As I explain in these books, intersex, hermaphroditism, and homosexuality, and in my book Transsexuality, as well as in my scientific articles on gender dysphoria and transsexual surgery, intersex conditions involve congenital physical abnormalities. In intersex cases, an anatomical abnormality may require surgical correction, and I perform those operations myself whenever they are medically indicated, regardless of the patient's age. These procedures have nothing to do with transsexuality. They are completely different conditions. The rationale for operating on transsexual individuals is psychological distress. Unfortunately, there is no convincing evidence that surgery itself resolves these psychological problems. Nevertheless, this remains the prevailing justification in current medical practice. The argument is that transgender individuals experience severe psychological distress, and that surgically changing their sex characteristics will resolve these problems. So let me ask you this. What was your psychological condition after surgery? Did you feel better? Did nothing change? Or did things actually become worse? How would you describe your mental and emotional state after the operation?
Yes, in theory, after undergoing these operations, a person should feel better. Based on my own personal experience, I can say this very consciously, and I want to say it openly. Unfortunately, the reality looks very different. That was true for me, for most of the people I have known, and, in my experience, for many other cases as well. After all these operations, even if complications had occurred, I should at least have felt psychologically better. These medical procedures are presented not only as physical interventions, but also as treatments that promise emotional balance and psychological healing. People are told, afterwards, you'll finally feel relieved. You'll find your inner center again. You'll recover psychologically. You'll be able to stand firmly on your own feet again. That is the promise. But for me, exactly the opposite happened. During the years after the operations, or rather, after that marathon of surgeries, instead of getting better, I became progressively worse and worse. There was a period when I could no longer manage even my everyday life on my own. I had to be admitted to psychiatric clinics. At times, I was almost in a psychotic state. I was under an enormous psychological burden. I no longer felt connected to myself. I truly couldn't make sense of anything anymore. I couldn't put my thoughts in order or distinguish what belonged where. My entire life had descended into chaos. Then substance abuse became part of the picture. Looking back, I see that as another expression of just how desperate my situation had become. When you're in such a state, you can no longer think clearly. Along with the hormones came profound disappointment, anger, emotional exhaustion, and eventually substance use as well. All of this dragged me downward, step by step, as though I were walking down an endless staircase. By then, medicine was no longer there to help me. The hospital had already told me, "Your file has been closed." I was left to cope with my life entirely on my own, and I almost couldn't. It completely drained me. I was still young. I had entered transition with an enormous hope that I would finally find happiness. But that never happened. Instead, I was left with overwhelming disappointment, an irreversibly damaged body, and a psychological burden that grew heavier rather than lighter. Instead of healing, my mind sank deeper and deeper under the weight of everything I was experiencing. Eventually, in 2006, I reached a point where I no longer wanted to live. I simply had no strength left. Today, I deeply regret what happened, but we are talking about that period of my life. At that time, I wanted to end my life. I attempted suicide. For me, life had completely lost its meaning. Because of the disappointment, the irreversible physical damage, and all the psychological, physical, and emotional suffering, I felt an overwhelming burden of pain and despair. I no longer knew how I could go on living. Fortunately, thank God, I survived that suicide attempt. Today, I am ashamed of it. But that attempt was an expression of the genuine and absolute despair I was experiencing at the time. Even so, I have come to believe that trying to end one's life through suicide is ultimately an act of surrender to despair. It is something that requires deep personal reflection and inner healing. That is exactly what I have worked on over the years. For a very long time, I carried an immense burden of guilt because of that suicide attempt. Afterward, of course, came hospitalization, psychiatric treatment, and everything that followed. I did everything within my power to rebuild my life. I made a deliberate decision to change my entire environment. I left the city behind. I distanced myself from my former neighbors and my previous social circle. I moved to the countryside, where I could live in peace and quiet. I spent time in a monastery and found a sense of purpose there. In other words, I did everything I possibly could to restore some order to my life. I tried to build a new life despite living without sexuality. Thankfully, over the years, I succeeded surprisingly well. Gradually, I achieved a certain degree of stability. My life became calmer, and little by little I began to accept, this is now my reality, and I have to learn how to live with it. But I was never truly happy. What was striking was this. I was never really able to function as a woman. Deep inside, I always felt under pressure. For years, the only thing I could do was focus on my outward appearance. That became my entire life. As long as I wore those clothes and presented myself publicly as a woman, the growing sense of calm and gradual psychological stabilization allowed me to find a certain sense of security in the role of Nadia. And a sense of security does provide a certain degree of stability, but it was still a very long way from genuine happiness and the freedom to truly be myself. Yes, I achieved that stability only through enormous effort. That feeling of security gave me many more years of life, years in which I was, to some extent, able to return to everyday life. I rebuilt my routines and gradually created a new structure for my life, allowing me to become active again. Yet, despite all of that, there was always something missing inside me, a strange feeling. I still felt like a stranger in my own body. I still could not find my true inner home, the place where my soul truly belonged. As people grow older, they begin to reflect more deeply. They evaluate their lives more honestly and start seeing things from a different perspective. That is exactly what happened to me. I confronted these questions on a spiritual level, on a deeply personal level, and in the light of my faith. Why can't I find my inner home? Even though I had found a certain sense of security in the role of Nadia, even though that role had never truly included a satisfying sexual life, the answers slowly began to emerge. It came quietly, but with each small step it became clearer and stronger. Gradually, I began to feel restless again. More and more, I realized that the role of Nadia was exactly that, a role. It was a mask, a facade, an illusion. When a person is truly honest with themselves and listens to the deepest part of their own soul, one realizes something very clearly. Although I had found a certain sense of security as Nadia over the years, I call it a technical sense of security, I had never truly arrived. I knew how to behave in that role. I knew who I was supposed to be. I knew where I belonged socially. I knew how people were likely to respond to me. But I never experienced the feeling of, I have finally arrived. I have finally found my place. That feeling was never there. Gradually, I realized that I had to begin questioning myself once again. I had to face a difficult question. Why do I increasingly feel as though I am wearing a mask? Why is this illusion becoming heavier and heavier to carry? By then, I had already lived almost 20 to 25 years as Nadia. At the same time, I felt an ever-growing sense of exhaustion. It was not ordinary tiredness. It was a profound, overwhelming exhaustion. Day after day, I found it harder and harder to cope with the constant social interactions of everyday life. From the outside, people saw Nadia, but internally, I was constantly monitoring every encounter. Does this person see me as a woman? Do they see me as transgender? Or do they genuinely see me as a woman? Do they find me attractive? Are they judging me negatively? Am I being devalued right now? Or are they simply treating me like everyone else? Living like that requires an enormous amount of emotional energy. And that became the beginning of a new realization. I am living an illusion. I was still playing a role. I decided to start over from the very beginning. I told myself, I have the courage to let go of this illusion. Yes, that illusion had given me a certain sense of security, but it only allowed me to function. It never gave me a truly authentic life. I think that after the age of 50, you begin to understand something very clearly. Life teaches you that no one can live a genuinely happy life based on an illusion, nor can we build a meaningful and wise life upon something that is not real. That is why I finally made the decision to detransition, to step away from my transition and return to living as myself. Even if it meant facing new hardships, even if it meant confronting new challenges, even if it meant once again finding myself on the margins of society, even if I had to explain myself all over again, even if I had to come out once more, even if I had to start from zero again. So what? Yes, I would lose many things. Yes, many new difficulties would lie ahead, but I would finally be doing one thing right. By finding the courage to let go of the illusion and saying, "Here I am," I was finally showing genuine respect for my own life. I am Chris. Chris transitioned. Chris lived in illusion for 30 years. Chris has feminine features. Chris has scars. Chris has made many mistakes in life, and yet Chris can live. And Chris is enough exactly as he is. Thank God, after many years of profound inner struggle, I finally found that courage. That is why I am sitting here today. I am truly happy, and I feel a deep gratitude for my life. I am no longer pretending. I no longer care how I appear to other people. I am Chris. I am Chris with everything that makes me who I am, with my strengths, with my weaknesses, with my non-functioning sexuality, with my feminine features, with my scars, with my disappointments, and with my mistakes. And that is enough. Life has carried me through all of this. I am still alive. Isn't that a miracle? Today, I see things differently. Life has taught me some extraordinarily difficult lessons. Now the challenge is to say yes to those consequences as well, to accept my life exactly as it is, to accept the consequences of my own decisions. And now I move forward with everything that I am and everything I have experienced. And it is worth it, because I feel an immeasurable gratitude for my life. I believe that, even at the very last moment, I managed to make the turn before it was too late.
As you can see, these surgeries are performed on the premise that they will improve psychological problems. Unfortunately, not only is there no convincing evidence to support that claim, but Chris's own experience also illustrates the opposite. More recent publications, particularly those published after 2020, suggest that psychological problems do not improve following gender transition surgery and may, in fact, worsen. Earlier studies had already pointed in that direction, but the studies reporting favorable outcomes, many of which had substantial methodological limitations, received much greater attention. When we discuss this issue, people often ask, but aren't there many studies showing that mental health improves after surgery? Yes, we are familiar with those studies as well. However, systematic reviews, meta-analyses, and comprehensive evidence assessments that have evaluated the entire body of literature conclude that those studies are generally not of sufficient methodological quality to provide reliable evidence. One of the best-known examples is the 2016 U.S. Centers for Medicare and Medicaid Services (CMS) evidence review. The available studies were examined comprehensively, but many were judged to have significant methodological weaknesses. The report concluded that these studies could not reliably demonstrate that surgery resulted in meaningful improvements in health outcomes. Studies with stronger methodology likewise did not demonstrate a significant improvement in psychological outcomes before versus after surgery. Based on that assessment, CMS decided not to provide routine coverage for these procedures on the basis of the available evidence. That review dates back to 2016. Since then, especially after 2020, newer studies have reported that psychological problems do not necessarily improve after surgery, and in several cohorts, appear to become more prevalent. For example, A study published last year analyzed data from approximately 107,600 transgender individuals in the United States over a 10-year period, 2014 to 2024. It reported significantly higher rates of psychiatric disorders, including anxiety, depression, substance use disorders, and suicide-related outcomes, among those who had undergone surgery compared with those who had not. Yet improving these very psychiatric conditions has been presented as one of the principal justifications for surgery. According to these findings, they do not improve, rather they appear to worsen. Physical health outcomes are also a major concern. A nationwide Finnish study, published recently and based on national registry data, reported that among transgender adolescents who underwent hormonal and surgical interventions, the prevalence of psychiatric disorders increased substantially during follow-up. Depending on the subgroup, reported rates rose from approximately 10% to around 60%, and from roughly 20% to approximately 55%. In other words, according to these findings, psychiatric problems did not decrease, they increased several-fold after medical transition. So we must ask again, if the primary rationale for these interventions is improvement of mental health, where is the robust evidence demonstrating that benefit? Instead, there are studies suggesting the opposite, nor are the harms limited to psychiatric outcomes. Because of the long-term effects of cross-sex hormones and the risks associated with multiple surgical procedures, these individuals may also experience reduced overall survival. For example, a Danish cohort study reported that while average life expectancy in Denmark is approximately 78 years for men and 82 years for women, the average age at death among surgically transitioned individuals in that cohort was 53.5 years. Similarly, data from the Amsterdam cohort in the Netherlands have reported significantly reduced survival among both trans women and trans men who underwent medical transition. Taken together, these findings suggest that these procedures may not improve psychological health, while their physical consequences can be substantial. As a result, we are faced with individuals whose physical and psychological conditions may both be worse after treatment. Should we call this malpractice? Should we call it iatrogenic harm? Medicine defines harm caused by healthcare interventions as iatrogenic harm. That is the term I use. I've published academic papers discussing this issue in detail. Another very important topic concerns regret after gender transition surgery. First, we should distinguish between regret and detransition because these two concepts are often confused. Regret is an internal psychological experience. It refers to a person's thoughts or feelings. For example, if someone thinks, "I wish I had never undergone this surgery," that is regret. It does not necessarily involve taking any action. Detransition, however, is different. It is an active process. A person who regrets the transition may later decide to detransition, which usually involves concrete actions, medical, legal, or social. These are two distinct concepts. A common criticism is that the published literature reports post-operative regret rates of around 1% or even lower, and therefore people argue that concerns about regret are being exaggerated. However, we believe that these reported rates underestimate the true prevalence, and there is literature suggesting that regret is likely underreported. I would like to hear your perspective as someone with first-hand experience. Although regret may be much more common than the published figures suggest, why do you think the literature reports such low rates? What are your thoughts on this issue?
Yes, this 1% figure, I honestly consider it complete nonsense. It is an old number. I know it well because people keep bringing it up whenever I speak publicly about this issue. They always say, "Yes, but it's only 1%. These are very few people. These are only exceptional cases." Frankly, I can no longer tolerate hearing that 1% figure. It comes from older data, dating back to around 2016. Yet the major expansion of the transgender movement, the rapid growth in transition-related healthcare, and the broader social phenomenon that we see today largely occurred afterward. Therefore, it seems obvious to me that the number of people who may eventually choose to detransition will be significantly higher, both today and in the future. It is also entirely understandable that these numbers emerge only after a considerable delay. Moreover, even today, it is almost impossible to obtain a reliable and honest database regarding detransition rates. Why? Because many people who detransition are so disappointed by the clinics that facilitated their transition that they never return there again. They do not go back to the clinic and say, "I want to detransition." As a result, many of these individuals never appear in the official statistics. Today, in Switzerland alone, I personally know at least one or two detransitioners in nearly every canton. None of them officially returned to a hospital to report that they were detransitioning. Consequently, none of them were included in any official database or statistical record. That is simply a fact. There is one study that I personally find particularly meaningful, the work of Kinnan McKinnon. As you know, he is a trans man and a professor at the University of Toronto. His work received considerable attention and was even discussed in the New York Times. In that study, he discussed detransition rates in the range of approximately 11% to 16%. He also suggested that among young people who had begun social transition, and in some cases even started hormones, rates of discontinuation could reach as high as 30%. Those numbers are dramatically different from 1%. 30% versus 1%. But do you know something, Professor? At the end of the day, people are constantly arguing about percentages. Whether the true number is 1% or 30% is not what matters most to me. What matters to me is something much simpler. If even a single person is mistakenly placed on a transition pathway and undergoes medical transition unnecessarily, then that is already one person too many. Even if it were only one individual, I would want to help that person. I would want to protect that person. I would want to spare that person from the potentially irreversible and profound consequences that can result from entering a transition pathway by mistake.
Thank you. I'd like to add a few comments here. The way regret is defined in much of the published literature is so restrictive that reporting even a 1% regret rate becomes almost inevitable. Let me explain. If a person undergoes gender transition surgery, they may ultimately require 5, 10, or even 15 additional operations because of complications. Chris underwent 16 procedures. Among the patients I have personally followed, I have seen individuals who have undergone 17, 19, 20, and even 21 operations. According to the criteria used in some of these studies, a person is counted as experiencing regret only if they return to the treating team and explicitly say, "I regret my transition. I want to return to my previous sex and I am requesting the surgeries necessary to reverse what was done." For example, there is a well-known Swedish study published in 2014 by Cecilia Dejne and colleagues that used an extremely strict definition of regret. Under that definition, an individual had to actively seek legal or surgical reversal in order to be classified as regretful. But why would someone who has already endured years of surgery, multiple complications, and often conflict with their physicians, return and request something that they know cannot fully restore their original anatomy? These individuals understand that a complete return to their previous biological anatomy is impossible. If regret is defined so narrowly, it is hardly surprising that the reported rates remain very low. At the same time, as Chris has already mentioned, even within the existing literature, there are reports, particularly among individuals in earlier stages of medical transition, such as hormone treatment, showing figures approaching 30% or even 40% in some settings. We believe the true numbers are likely to be higher still. One of the main reasons, and this leads directly to my next question, is that many people experience regret but are unable or unwilling to admit it. That is one of the most important factors. Another is the tremendous pressure placed upon those who do speak openly. I refer to this as detranophobia, hostility toward detransitioners. Consider Chris. He underwent hormones. He underwent surgery. He lived through the entire transition process. Now he is simply describing his own personal experience. He is saying, I went through all of this. I underwent surgery. I took hormones. But the promised outcome did not materialize. I regret my decision. Yet for expressing that personal experience, he has even received death threats. And Chris is certainly not the only example. In such an atmosphere, where individuals fear social condemnation or intimidation, it becomes extremely difficult to obtain honest reporting. For that reason, I believe the true prevalence of regret is considerably higher than the rates reported in the literature. Now, Chris, I would like to ask what I consider one of the most important questions of our discussion. Despite experiencing significant physical and psychological difficulties, you have said that for many years you continued to present yourself publicly as a happy trans woman. You have described this yourself. I have observed something similar among many of the patients I have followed. Even when they experience serious complications and are clearly struggling, many continue to present themselves as happy, or at least find it difficult to acknowledge feelings of regret. This appears to be a common pattern. You have said that you maintained the role of a happy trans woman for nearly 30 years. Why do you think so many transgender individuals continue to present themselves as happy even when they are suffering? Why is it so difficult to acknowledge regret? Do you think this is a form of rationalization, or could it be related to what psychology calls the sunk cost effect? The tendency for people who have invested enormously in something to find it psychologically difficult to acknowledge that the outcome has been disappointing or harmful. What are your thoughts on this?
Yes, I think your observation is absolutely correct. I see it the same way. I experienced it in my own life, and I have seen the same pattern in the life stories of many other trans people. When a person invests so much in reaching a deeply desired goal, an intensely idealized image they have created in their mind, and is willing to sacrifice so much for it, only to realize later that it has not become reality, it naturally becomes increasingly difficult to turn back. The further a person moves along that path in pursuit of perfection and the achievement of that goal, the harder it becomes to let go. Even returning to a reality check, or simply admitting, all right, this did not turn out the way I expected. I did not reach my goal in the way I had hoped. Perhaps I now need to rebuild my life, becomes extraordinarily difficult. Doing that requires an immense amount of courage and self-reflection, that is, the willingness to examine oneself honestly. Many trans people, and I find this deeply striking and profoundly saddening, it genuinely makes me think, choose to remain within their illusion. They stay inside the reality they have created for themselves. For example, when I ask someone, "How are you?" I often already know that they have experienced surgical complications or are suffering from long-term damage. Yet when I ask, "How are you?" I frequently hear the answer, "I'm doing great, everything is perfect." But I know very well that this is not true. To me, this is a psychological phenomenon that deserves to be understood. I believe that the trans person is, in some way, trying to preserve their illusion. Because if they were completely honest and said, yes, I invested so much in this goal, I gave so much to become a trans woman or a trans man, but in the end, I did not reach the goal I had hoped for, that would be an extraordinarily painful admission. That is why maintaining the illusion is often easier. As long as the illusion remains intact, a person does not have to hold a mirror up to themselves, at least symbolically. Speaking the truth, admitting it to oneself, acknowledging that one has, in a sense, failed to achieve the intended goal, these things are incredibly difficult. They require a profound process of inner reflection and a great deal of courage. My observation is this: the more a person has invested in this journey, the harder it becomes to let go. It becomes increasingly difficult to say, stop, to be honest with oneself, and perhaps to acknowledge that one's life now requires a correction through detransition. I believe this has a great deal to do with self-protection. It has to do with shame. In fact, I sometimes think it touches the very foundation of a person's life. By that point, the trans person has already been hurt. They have already suffered harm and endured many hardships. Yet despite all of that, they cling so tightly to the illusion that they want to preserve it at all costs. Because the moment they honestly say, this goal did not turn out the way I had imagined or hoped, the entire structure, the entire illusion, collapses like a house of cards. And that is profoundly painful.
Chris, from everything you have told us, as well as from our own clinical observations, we know that many individuals who experience identity problems, gender-related distress, or identify as transgender are, unfortunately, not receiving sufficiently thorough psychiatric evaluations. Psychological follow-up is often not conducted as comprehensively as it should be. Instead, many are directed rather quickly toward transition, that is, hormone treatment and surgery. Unfortunately, this is what we observe, and it appears that your experience followed a similar pattern. So let me ask you this. In your opinion, what would have been the right approach? What should change? For example, if you had undergone a longer period of psychiatric and psychological assessment, if your therapists had focused on your childhood trauma, your physical and emotional experiences, and the developmental issues associated with those early traumas, how do you think your situation might have been different? And how might the outcome be different for many other young people in similar circumstances? In short, what do you believe should be the appropriate approach?
In my opinion, psychotherapy today often moves far too quickly. In many cases, the first conclusion reached is that the person has a transgender identity. Why? Because a child or adolescent's experience of feeling transgender may actually be only the visible symptom. Underneath it, there may be trauma, autism, borderline personality disorder, sexual assault, sexual abuse, trauma-related dissociation from the body, or, as in my own case, early childhood trauma. In other words, the transgender feeling may sometimes be a symptom of underlying clinical issues. That is precisely why I believe psychologists have an urgent professional and ethical responsibility to first investigate the underlying causes. They should carefully examine and rule out other possible explanations by conducting a thorough differential diagnostic assessment. They should not simply adopt an exclusively affirming approach. Instead, they should engage in a careful evaluation process with the client, a process that takes time and may at times be uncomfortable for the client. Ultimately, this process should involve examining the person's entire life history in a holistic way and asking, why do you identify as transgender? Where does this feeling come from? What are the underlying reasons? Because only in a relatively small number of cases is a transgender identity itself the primary underlying issue. In those cases, appropriate solutions can still be explored. And in such situations, I believe there may be medical interventions that can, so to speak, make life easier for the individual. However, that is not the main point I want to emphasize. Those cases represent only a small minority. If evaluations were carried out with the degree of care required by ethical medical practice, I am convinced that, in a large proportion of cases, we would discover that the transgender feeling is not the cause, but a symptom. And in my view, this is the much larger group we have been seeing in recent years. These individuals certainly need treatment, but they do not need a scalpel or hormones. This distinction is extremely important to me. I want careful assessment, and careful assessment requires time. Therefore, whether in Turkey, Switzerland, or the United States, I believe we need to rethink how transition pathways are structured. The focus should shift away from surgery and hormones. Even if medical transition ultimately remains an option, it should truly be the very last, not the first. I hope that medicine will once again place psychotherapy at the center of care and work with patients there first. I am completely convinced that there are many young people who, if they were given the opportunity to engage in this process properly, could learn to cope with their gender dysphoria. They could also be shown that it is possible to build a meaningful and fulfilling life while remaining in their biological sex, even if dysphoria continues to exist. Yes, I believe that is possible. And wouldn't that benefit all of us? It would be better for patients' health. It would reduce unnecessary interventions. It would reduce irreversible harm. It would be better for patients, better for physicians, better for healthcare systems, and ultimately better for society as a whole. That is my hope.
One of the questions I am asked most frequently is this: what is the primary motivation behind transgender activism? You are now a detrans activist, but for many years you were a trans activist. During that period, what was your primary motivation? Was it the difficulties you experienced because of gender dysphoria and the accompanying psychological problems? Was it the influence of advocacy groups, financial support, the media, the pharmaceutical industry that supports transgender activism, or something else? And the second part of my question is this: what do you think are the most rational ways to respond to or address this activism?
I have asked myself this question many times. I have spent a great deal of time reflecting on it and trying to find an honest answer. My observation is this: transgender activism often appeals to people who are insecure and emotionally vulnerable. I was insecure at that time, and that was when I entered the transition process. Through that process, I also became part of the transgender community. There, I was celebrated. People told me, "Wow, you're amazing. You're doing great. You're so brave. You're doing the right thing. We love you. We're proud of you." I received applause from every direction, and within that applause, I found a sense of belonging. I thought to myself, what I'm doing must be right, because everyone around me says it's wonderful. What I never realized was that I had already boarded a train. At that time, that train was moving from what had once been a subculture toward what I now believe has become a harmful transgender ideology, and I was sitting in the front carriage of that train. Today, I deeply regret that. That, in my opinion, is also how transgender activism functions. When people are searching for meaning, when they are vulnerable, when they do not feel that they belong anywhere, and when they do not know where their lives are heading, they can find an extraordinarily strong sense of belonging within the transgender community, often through social media, peer groups, or closed online communities, what are often called echo chambers. Immediately they are told, "Come join us. You belong with us. You are part of our community." It is an extremely powerful community. However, within that community, being transgender is no longer viewed as simply one aspect of being human. Once a person enters that environment, being transgender gradually becomes their entire identity. Everything in life begins to revolve around it. In addition, transgender activists receive support from advocacy organizations, and they are also supported by the pharmaceutical industry. Large amounts of money are involved. The pharmaceutical industry naturally has financial interests because it knows that every person who enters medical transition may become a lifelong customer, generating ongoing revenue throughout their life. So there are powerful forces operating from many different directions. In my view, the only real way out, and this is the step I eventually took, is to make a radical break and simply return to reality, to return to ordinary society. Of course, after I made that decision, I was abandoned. Today, I am viewed as an enemy and as a threat. The very same people who once applauded me now accuse me of being transphobic and of spreading hatred against transgender people. What they fail to understand is that my perspective, and the perspectives of many others, reflects a different reality. There is not just one single reality defined by transgender ideology. Other realities exist as well. Things that many people regard as completely ordinary are perceived by transgender activists as threatening because they challenge the foundations of their worldview. And whenever the foundations of someone's worldview are challenged, fear naturally arises. When fear takes over, it becomes difficult to hear another person's questions as a sincere attempt to engage in an important and necessary human conversation. It becomes difficult to recognize that open discussion matters, or that differences of opinion are normal. Instead, a person can become so deeply immersed in an ideology that everything outside it appears only as an enemy or a threat. And once something is perceived as a threat, the natural impulse is to fight it. Unfortunately, that struggle often turns into hatred. I have experienced that hatred myself. And Professor, you have experienced it as well.
Chris, I'd like to conclude with one final question. Your birth name was Christian. After your transition, you took the name Nadia and lived for many years as a trans woman. Later, you acknowledged your regret and began the detransition process, seeking to return to living as your original biological sex. Today, your name is Chris. You dropped the Tian from Christian, leaving only Chris. Why? What message are you trying to convey through that choice? Was it a conscious decision? Does it symbolize the idea that what has been lost cannot simply be restored?
That's an interesting question. At first, it may seem like a rather unusual one. People ask me quite often, why Chris? Why not simply go back to Christian? For me, however, this decision was very important. If I had gone back to the name Christian, it would have implied that I was returning to the young Christian I once was. But life doesn't work that way. We can never truly walk backward. In life, we can only find the courage to say yes to life and continue moving forward. That is why Chris represents something new for me. At the same time, it honors and respects my origins, because Christian is still present within the name Chris. Yet Chris also gives me the freedom to move forward. Yes.
Chris, that brings me to the end of my questions. Your answers have been very thoughtful and informative. Before we conclude, is there anything else you would like to say? Is there a message you would like to leave for young people, parents, or society as a whole?
Absolutely. There are two things I would like to say. The first is this. Looking back on my own story, one thing has become absolutely clear to me. You can never treat a psychological problem from the outside with a scalpel, nor can you treat it simply with hormones and surgery. What is urgently needed is psychological work, an honest confrontation with one's own inner self. For me, this has been one of the greatest realizations of my life. Secondly, I believe it is very important that we have a message for young people. If I could say one thing to every young person who is searching for themselves, it would be this. Hey, do you know something? You are enough exactly as you are. You are valuable. You are unique. You are worthy just as you are. There is nothing in this world that requires you to alter your body simply to fit a stereotypical role or to live up to the highly idealized and distorted images promoted on social media. You do not have to change yourself as radically as the transition process demands. There is absolutely nothing in this world that makes such a step a necessity. Stay as you are. Ideally, you are given only one healthy, functioning body in this life. Please cherish that healthy body and take good care of it, because it is your body. It belongs only to you. It is the only body you will ever have. Take care of it.
Chris, thank you very much. Your answers were highly informative and deeply satisfying. I hope our viewers will also benefit from them, and I believe they will. I would like to conclude with a brief summary. As you have seen, everything I've described in my academic publications on transsexual surgery, in my books and in my lectures and seminars, has also been confirmed here by Chris, someone who has personally gone through this entire process. Ultimately, both Chris and I wish to convey the same message. Individuals with transsexualism, young people experiencing gender dysphoria or gender-related distress, in short, transgender individuals, deserve more compassionate and more careful medical care. Unfortunately, current mainstream medical practice often fails to provide them with the level of care, caution, and compassion they truly need. Transsexual surgeries and hormonal interventions do not treat these young people's psychological problems. Rather, in our view, they sacrifice them to interventions that fail to address the underlying causes. Our message is that these individuals deserve the compassionate, careful, and ethically grounded medical care that they are currently being denied. That is what I am trying to promote. That is also what Chris Brönimann, who personally underwent this entire process, including all of its complications, is trying to promote. Yet unfortunately, both Chris and I are labeled as transphobic. We must find a way to break this vicious cycle. Unfortunately, our own efforts alone are often not enough. I hope that one day we will overcome this barrier and succeed in delivering this message to the young people who are struggling with these issues. In reality, what we are asking for is very simple. We simply want people to listen to us as well. Let them hear another perspective. Let them have access to the available scientific evidence and confront the realities documented in the medical literature. If they are going to make life-changing decisions, let them do so after becoming familiar with all of the available evidence. As Chris said, if I had received more careful care and better psychiatric follow-up, my life might have turned out very differently, and I believe that is entirely possible. That is what we are trying to achieve. I sincerely hope that our message reaches everyone concerned and proves helpful. Thank you once again, Chris. It has been a great pleasure to host you here in Istanbul. I sincerely hope that your message reaches young people who are facing these challenges and, as you yourself have said, helps alleviate at least some of their suffering. I would like to conclude this program by quoting a few of Chris's most memorable statements. He mentioned some of them during this interview, while I heard others in his previous interviews and conversations. Chris says, "We live in an age that tries to drive out the wound of the soul with a surgeon's scalpel." I believe this aptly describes contemporary transgender surgery. He also says, "You cannot heal the wound in my soul by creating wounds in my body." And another profound statement, "You can silence biology, but you cannot defeat it. Sooner or later, biology will reclaim its rightful place, and when it does, all of your debates will never erase our suffering." There is little more that needs to be said. No debate today can restore the organs these individuals have lost or give back the functions that have been irreversibly lost through these procedures. Yet, unfortunately, much of today's public discussion proceeds while ignoring these realities, and that is deeply regrettable. As I have stated before, I believe these operations do not change biological sex. Rather, they abolish sexual function and leave individuals permanently impaired. I want to emphasize that point once again. In my view, a vicious cycle has developed. Psychologists evaluate young people who are experiencing psychological distress and then refer them to surgeons. It is almost as if they were saying, "Dear colleague, this young person has psychological problems. I have been unable to resolve them. Please take over and alter the biology instead." The surgeons then proceed with the operation, effectively saying, "Very well, we'll take care of it." As a result, the person's biology and body are also altered. So what begins as a psychologically distressed individual with an otherwise healthy body ultimately becomes someone with a permanently altered body, physical impairment, and, in many cases, psychological difficulties that are even worse than before. Unfortunately, this is how I would summarize today's prevailing medical approach to transgender medicine. I sincerely hope this program will be beneficial for young people experiencing these struggles and that our message reaches those who need it. Thank you once again, Chris. It has been a pleasure to host you in Istanbul. I hope tomorrow you will return to Switzerland with fond memories. Thank you.
Thank you very much from the bottom of my heart for this interview, for your invitation, and above all, for your wonderful hospitality here in Istanbul.